Healthcare quality, public reporting. Does public reporting of healthcare quality performance measurements and data lead to improved quality in healthcare? We will analyze the following questions. What is healthcare quality? What is the purpose of quality reporting in healthcare? What are the advantages and drawbacks of public healthcare quality reporting? Who reports healthcare quality performance measures? Do consumers use healthcare quality data? Where does the data come from? Is it reliable? And what is the future outlook? What is healthcare quality? Healthcare quality is defined by the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Improving healthcare. In 2001, the Institute of Medicine, known as IOM, authored a report, Crossing the Quality Chasm, a new health system for the 21st century. This had recommendations about how organizations can improve upon their quality of services. The report focused on the following areas regarding quality healthcare services: overuse, underuse, and misuse in regards to patient treatment, and measuring this type of data and how it can help improve upon quality and efficiency in healthcare. Healthcare quality performance is measured by three categories: structure measures, process measures, and outcome measures. Structure measures are used to evaluate the physical and organizational resources available to support healthcare delivery, such as nurse-to-patient ratio or the number of hospital beds. Process measures evaluate whether activities performed during the delivery of healthcare services are delivered satisfactorily. An example of process measurement would be how long from the time the physician ordered a patient's discharge to the actual discharge. Outcome measures evaluate the results of healthcare services, what the effects are of the structure and process measurements. Examples of outcome measures are the number of readmissions to the hospital within 30 days or the mortality rate of post-surgical hip fractures. By using these measurement systems, organizations can see where they excel and what areas need improvement. Public reporting began with an acknowledgement of the role of quality in healthcare. This evolved to focus on the prioritization of quality improvement and the development of systems to monitor, quantify, and incentivize quality improvement in healthcare. It is a strategy to address quality and cost in the healthcare system by providing stakeholders such as consumers, payers, and healthcare providers with information about the performance of providers and insurance plans. Public reports can allow for the comparison of cost, quality, and how satisfied patients are with service. Some of the advantages of public reporting are reduced information asymmetry between both patients and providers and payers, promote competition in the healthcare marketplace, apply pressure to reduce costs and improve quality, empower patients to become more active participants in their own care, and foster a culture of accountability, transparency, and efficiency. In today's healthcare world, the transformation of healthcare organizations becoming more transparent, high reliability organizations, and implementing cultures of safety are all positive attributes that derive from the use of public reporting. Unfortunately, while there are many positive impacts of public reporting of performance data, there are also some drawbacks to the system. Some of the drawbacks include reduced access to services if providers change who or what or how often they offer services in order to improve their own publicly reported quality scores, compromised data quality resulting in reduced confidence, in the data if there were attempts to manipulate the publicly reported data, reduced patient engagement and or negative outcomes if patient views a report and believes that they're receiving care from a high quality provider so that they don't need to be involved in their own care, as well as increased anxiety after reviewing mortality and medical error reports, resulting in worry about their own condition and subsequent care. Also, reports misclassifying providers and their status can result in a loss of market share. It can impact their contracting arrangements as well as their reputation. And lastly, if public reporting has results but no improvement or worsening of quality for any reason, so it has no impact at all. These negative outcomes can not only have detrimental effects to an organization, but to its patients as well. Public reporting data collection involves a variety of public and private data collection systems, including health surveys, administrative enrollment, and billing records, as well as medical records. Public reporting organizations are the Joint Commission, the National Quality Forum, the Leapfrog Group, Agency for Healthcare Research and Quality, Institute of Healthcare Improvement, and the Centers for Medicare and Medicaid Services. These are some of the institutes that have initiated the task of publicly reporting healthcare quality and consumer experience. We will focus on the Joint Commission, the Leapfrog Group, and the Centers for Medicare and Medicaid Services. The Joint Commission Quality Check. This is a website that provides limited information on healthcare organizations and lists the services, awards, and accreditations of different organizations. Performance is measured on a 3-point scale. 0 is insufficient compliance, 1 means partial compliance, and 2 means satisfactory compliance. There's no information on conditions or real quality indicators, though. In contrast, the CMS Hospital Compare website offers more comprehensive information on various organizations, including the organization's profile and general information, patient experiences, timely and effective care, complications, readmissions, mortality, and death rates, the use of diagnostic imaging, payment and value of care information. It's rated using the overall hospital quality star system. 1 to 5 stars are awarded, 5 being the best. It also utilizes the Hospital Consumer Assessment of Healthcare Providers and Systems survey. The Leapfrog Group is another organization that measures performance through their Leapfrog Hospital Survey and includes quality indicators. Results range between 1 and 4 green bars and has hospital safety letter grades A through F. They have Leapfrog Leaps, which are based on avoid harm, never events management, and appropriate use of antibiotics, ICU physician staffing, and readmission, and other situations like that. Comparing these 3 organizations, all of them use national standard quality indicators. The Joint Commission and CMS use process measures and clinical data. The Leapfrog Group mostly uses structure and process measures and collects data through their surveys. Do consumers use healthcare quality data? Many patients do not actually use healthcare quality data. Some may attempt to, and others may not, due to many different challenges. A lot has to do with the lack of understanding. As Shaler and Associates stated, we believe that consumers will use healthcare quality measures to assess and choose health plans, providers, caregivers, and health facilities, but only if that information is relevant to their concerns and packaged and disseminated so that they can easily obtain, trust, understand, and apply it. Some challenges to patient utilization of the healthcare quality data are the lack of measurement, there's a data format that's complicated, or there's poor distribution. Lack of measurement is a factor because there are not required mandates or standard quality requirements in place or enforced. Individual hospitals or providers may choose to measure and support whatever metrics they deem important to track. This may help them to individually set and meet performance goals, but the metrics may only be meaningful to their organization and not easily interpreted by an outsider, especially a patient. Variation in reported data will also occur, so usable insight into the metrics may be difficult, though the metrics may be well-intentioned. There are some incentives for reporting programs, but the information is usually geared towards what payers of healthcare plans desire to capture, and it doesn't focus on what's important for the consumer. Data format complicated. It has been found that there are three contributing factors for the slow adoption of available performance reports, and they're the invisibility of the quality gap, consumer understanding of quality, or lack thereof, challenges in using comparative performance information. When asked, patients stated that quality in healthcare means that they would consider their provider patient-centric, their safety factors, and technical skills of the facility. It is only when guided towards such topics as near event rates, errors, and average procedure costs are patients sometimes realizing that this information should not only be considered by themselves, but required to be provided by a healthcare industry. It must also be considered that too much information, especially if it's not focused and presented clearly for an outside party like a regular consumer, will have a similar effect. It was found in testing reports with consumers, it was observed that what people do not understand, they tend to view as less important. Poor distribution. The healthcare data that is available to patients via the Joint Commission, AHRQ, and the Leapfrog Group can be helpful, but it is not easy to see how many options at once. It takes considerable effort to visit the many different sites with information, and then the patient must gather and compare factors that are important to them. This is too time-consuming and not very patient-centric. The plan to distribute healthcare quality data must be well thought out and has to be considering of the audience. If the true intention is to better inform patients so that they can make more educated decisions regarding their care, then they must be able to use what they're given. Technology is highly relied upon to share this information, but not everyone in the workforce has equal access to these tools. Quality data and performance measurement. Performance measurements for quality data in healthcare outlines the responsibility for providers to appropriately measure their responsibilities and be held accountable to set standards and goals. The standards may be at a company or a state-mandated level. It has been determined that healthcare consumers are no different than consumers of products and other services in the expectations to receive care that is reliable. Optimal care is a human right. Reporting systems are designed to be part of a public system so that healthcare organizations may be held accountable for their performance. Data use and quality improvement. Data is the cornerstone of quality improvement, according to the U.S. Department of Health and Human Services. They say it is used to describe how well current systems are working, what happens when changes are applied, and to document successful performance. This is a snapshot of data flow in a complex healthcare system. As you can see from this illustration, which is from AHRQ, data comes from many sources, such as government programs, insurance health plans, state databases, health promotion organizations, physician practices in hospitals, as well as individual patient medical records. On top of that, additional information comes from consumer surveys, government surveys, and national statistics. This dynamic and complex data collection system contributes towards difficulties that currently exist in obtaining quality data. This image is from Healthcare Catalyst, and it describes the factors that contribute to the difficulties surrounding the procurement of healthcare data. Those are the location of the data, how it's in multiple places, the data structure, inconsistent and variable definitions, evidence-based practice and new research is coming out every day, the complexity of the data, and changing regulatory requirements. Some barriers to ensuring quality data in healthcare organizations are issues related to the timing of the data, misinterpretation of metrics, and poor data quality characteristics, also known as dimensions. The timing of the data is important. Long lag times from when data becomes available and when it's actually reported can reduce the accuracy of the data. The data is less likely to represent or capture the actual current conditions or demonstrate actions taken to improve care. Unclear guidelines on what is being reported and how it must be reported can cause misinterpretation of metrics. 6. Data quality dimensions. High quality data needs to have 6 characteristics in order to produce useful and meaningful performance measures. These dimensions are completeness, uniqueness, timeliness, validity, accuracy, and consistency. A few recommendations to improve the area of quality in key metrics are to standardize these key metrics and provide set definitions of what they mean and outline and make them mandatory and consistent across the board. This change would support the second improvement suggestion, which is to work towards improving the ease of use of healthcare quality data available. Improvement to marketing material could help explain what the information means to the patient and truly demonstrate how information can empower them in their decision making. Lastly, the distribution plan for these improved tools must consider all target audiences and take a multifaceted approach by making the information available through print, online sites, and live Q&A sessions with trained personnel. Healthcare quality has been a focal point for necessary improvement over the past 2 decades. Due to this, there has been increased attention to how much variation exists in the public reporting of quality data. The creation of organizations like the Joint Commission, CMS, and Leapfrog Group have led to improved visibility and quality through improvements, but they are still needed to further develop to fully improve care. Consumers have recently begun to believe quality is related to safety, patient centricity, and technical care. There is increased interest in using patient-level data analytics to support a broad range of healthcare decisions for patients, providers, payers, and policymakers. The introduction of electronic health records, EHRs, has helped to increase patient engagement through the expansion of access to and management of patients' own personal healthcare data. However, even with national standards established and pressure from healthcare organizations to improve metrics in EHR systems, a gap remains in how quality data is retrieved as well as how it's presented to consumers. Though efforts to improve public reporting have begun, there's a long road ahead in order to entirely improve care. The goal of public reporting on healthcare quality. This is an image from Centers of Medicaid and Medicare Services. Ideally, information data would be exchanged between both healthcare professionals and patients and different measurement and reporting organizations, which would then be clearly presented and distributed to the patient, resulting in better, more informed care. Future outlook. In order to improve public reporting and healthcare quality, alignment of data definitions and performance measures is needed. Also, a consensus on essential data content and documentation standards is a necessary prerequisite for high-quality data in the interconnected healthcare system of the future. Health information technology, health IT, may have the potential to improve the collection and the exchange of data. Until data is integrated across entities and national standardization approaches are implemented, redundancy will remain in data collection. Looking into the future, supporting and potentially partnering with Patient-Centered Outcome Research Institute, otherwise known as PCORI, could lead to impactful and sustainable improvements in how healthcare data is measured, recorded, and reported to patients, ultimately leading to a long-term improvement in care.